So welcome everyone to Using Cultural Humility to Promote Person-Centered Care. And so my name is Diane Padilla. If you don't know me and haven't been here with me before, maybe you've been with one of my colleagues here. I work for the Northeast Caribbean Addiction Technology Transfer Center. For those of you who do know me, who I've seen before, welcome back. So let me just go through some of the logistics. So something really important that has to do with this particular training. So we have an acknowledgement slide. Okay, the certificate of completion. Just to get this out of the way, so no one has to ask about this during the content. At the end of the session, what we typically do is we'll stop 2-3 minutes before the committed time that we're supposed to be here, and that'll give you just enough of an opportunity to submit an evaluation or our GIPers. And so there will be a scan code, and my colleague will put in the chat box a link, and that'll be easy for you. And so that's really important for us because that's another way how we justify bringing these presentations, these trainings, these webinars, these skill sets to you, and for free. And so that way, and another way of taking unofficial attendance is doing that as well. So if you send us that, then we can justify sending you out the certificates of completion. And so those will be sent out within a week or so, also along with a copy of the slide. Now, this particular webinar and this training is approved for 3 hours of KSAC, CPP, or CPS credentialing. And so, of course, you're expected to be visual and attend the entire session. And one extra point about this particular training is because for anyone who is a new KSAC applicant in New York State, you're now required to have part of the initial trainings, other than a 350-hour curriculum, you're also required to have 15 hours, or collectively 15 hours on cultural humility. And so this will meet 3 of those 15 hours. And we have more cultural humility specific trainings coming up now in March. And so this is the team I am pretty fortunate to be a part of. So Patricia Chappell, or Tree, if you don't know her, she's the lady who is in charge of all the logistics in all of our webinar deliveries, all the admin aspects of the work that we do. And so she is the one who will make sure that she'll send you the certificate of completion, and she'll follow up on you sending an evaluation in case you have a problem doing that. She's the one who'll send you a copy of the slides. And many times different trainings are different links and carry extra handouts. And so she's the one who's always going back and forth with most of you folks. So she's an important person to keep aware of. And this is the other important person, which is Mr. Clive Frederick, who's always on this webinar when I'm presenting. And so he's our master tech, and he's always behind the scenes administrating the technology behind these presentations, these trainings. And so if you have any kind of tech issues or audio issues, he's an excellent resource for that, and he can help you walk you through those issues. And so he can respond to you in the chat box under the Northeast Caribbean ATTC. And again, my name is Diane Padilla. I'm a research project manager here. I'm also an expert technical assistant and implementation specialist. So I help a lot of organizations and agencies incorporate screening, brief intervention, referral treatment in their settings. I do work with agencies around equity and inclusion, how to build capacity around that, and a myriad of other type of issues. And so here, this is a disclaimer, just saying that we are funded by SAMHSA, but we're responsible for the content we provide you. SAMHSA funds 3 different types, 3 disciplines in the technology transfer centers, and they have to do with addiction, mental health, and prevention and recovery. And so it's all a matter, it's really about how they wanted to respond to you as the workforce in terms of helping you continually gain the latest information and how to hone your skills and everything that's current, as well as keeping your continuing education credits so you can keep your licenses and your credentials. And the whole thing about this is that SAMHSA wants to make sure that as organizations and professionals such as yourselves promote best practices in whatever discipline you're in. But we typically focus at the ATTC with substance use disorders and substance use related issues. And they always intersect and overlap with mental health prevention, treatment, and recovery supports. And so, and then here I want to talk about the use of affirming language. And this almost that I can't tell you there is any particular training that I provide that this does not have a critical part, that this doesn't have a critical point in. And so language matters is still about emphasizing stigma-free recovery-oriented language to help the individuals who we're trying to reach out to or they're trying to access our services. All of it is about being able to support them and empower them. So we have a nice group here. It's nice to see everyone. So one of the things I want to make mention, so this is a very conversation-based type training. These are one of my favorites because this way you folks are all involved in it because your experience is that priceless. And so in order to help this be relevant and very specific within your capacity in your setting, it makes sense to help invite you to participate here. The only thing is that sometimes we get excited about certain things we want to say. And so I don't want to miss anyone's hand or anyone's voice. So I'm asking if you raise your hand. Is that okay with everyone? Okay, so that way we're practicing some of the skills that we're supposed to be practicing with our patients and our clients too anyway. And so that's great. And so the other thing about, let me see what else comes up. We will have an activity, breakout rooms. Let me see. So this is a very experience-based also type of training. So just to maintain an atmosphere that's conducive to learning and just making this kind of like your laboratory. Is there anything else that you want to add here as maybe guidelines that we want to include here? Okay, I'll take the lead. No problem. You can add later. Okay. Sure, not a problem. All right. So, all right. So let's just start us off because I do have some. Now I'm anxious to talk about this because I like talking about person-centered care. And so, yes, everyone, please, whoever's signing in, whoever's logging on, please follow suit and just keep adding your name. And that's great. We really appreciate that. So let me come back to here. So some of the things to consider, let's just start here. So some considerations, I'm not asking anyone to actually speak to this right now, not just yet. We will be discussing this as we go forward. So really what we should start thinking about, what I'm suggesting is to kind of just borrow my idea and kind of try to follow my lead, okay? Just so we can head in this direction and see how much of this is, it's gonna help you. So what we wanna consider is what does person-centered mean to us, to me as an individual and as a professional. What does strength-based mean to me? And how do I practice these values in my day-to-day work? And that's the thing. The interesting thing about going to training is great to have continuing education credits. It's great to have a conversation with our peers. And, because this is a little different from doing the direct services, we kind of get away with other people who understand what we do because we all do very similar work. And that's all great. But then we walk away. We have a few hours that we can add for our certifications or licenses, and then we don't necessarily understand how to apply it in our practice. So part of the content here is going to include that, is how to bring it into your practice, and then how to kind of go forward with a mindset of being more intentional. Defining person-centered care. So person-centered care, as far as according to the literature and according to an array of different experts, person-centered care means that individuals' values and preferences are elicited and once expressed, guide all aspects of care. That supports their health and the realistic life goals that they would have. And is also supposed to be respectful and responsive to the individual's culture, linguistic needs, and other social environmental needs. And so because we've always heard that no two clients are actually the same. And here is so specific about that, that even though we have folks that we work with people in a particular catchment area, in our agencies and or in our communities. And we tend to see a lot of the same common elements within different situations with different clients. It's still about understanding how their world and the different psychosocial factors in their world makes their issues or their needs very unique to them. And so person-centered care is really speaking to a tailored process. And it's based on a Rogerian therapy. Who can talk about Carl Rogers? And Carl Rogers, we met him first in 1940. Does anybody know about Carl Rogers? Has anyone ever heard of him? A few nods. Okay, that's a beginning. I can get that. I can get that. so, when person-centered care started, it didn't start as person-centered care. It came from client-centered care. So it's called Carl Rogers. So we came up with this idea in his years as a psychologist and working with different patients. He's always found that one of the most effective means of being able to collaborate and help an individual live, despite challenges, live their quality of life, it included certain factors. And so it was really about understanding what client-centered counseling was. And so at that time, back in the 1940s and such, there wasn't a lot of information or specific strategies about saying which one is the most effective. There were a few different theories. Carl Rogers came up with the client-centered counseling, and it included a few things and a few components that we're pretty familiar with. And so congruence was one of the factors. Is the idea, and we've heard this. Hear this in addiction counselor ethics. We hear this in all when we think about the 12 core functions. We think about all the different. I mean, even when we think about counseling 101 strategies, when we first started to be educated on different ways of engagement, we heard about the opportunity of being genuine with a particular person. When someone coming in for need, most people, if you're not being genuine, just not, if you're kind of disinterested in the individual, it's easy, it's not hard for the person to pick up on it. And so congruence is a really important part of this, where the individual, the provider themselves can be transparent and genuine with the clients. And so, and it says here, and these are his words, his honesty. I like to say transparency. I get a little funny about that word, but I think the transparency and being totally clear and being as authentic as you can be within an individual is the very things that will get you to being honest with the client. And so the other thing is the empathy. And we know that that's at the core of what you do. And so empathy is the ability to feel what the client feels. And when we think about that, what does that help you think about? What do you think about when we talk about empathy, bringing empathy to a conversation with a client or to their process? What comes to mind for you? Okay, being understanding what they're going through, putting ourselves in their shoes, connecting their feelings to our feelings, certainly compassion and connection. Okay, that's part of it. That's interesting. Being understanding, having mercy with them. Okay. Allowing them to be experts. And this is the empathy. I like that, Janet. Meeting them where they're at. Really, but the compassion piece is so important too. So thanks everyone for that. Looks like I'm looking at MI in there. And so the empathy piece is the very things that help us like listen in a way where we can start to kind of pick up on the emotions and what's going on with the individual and perhaps how it's impacting the individual and how they're expressing themselves and being able to like relate to those feelings and emotions that they may be going through during a tough time or during whatever time in their life. Or sometimes it's just an elated time in their life. You being able to empathize with them is really foundational to a therapeutic alliance. And that's something that we're all pretty familiar with. And so the other part of it is respect. The other factor that Carl Rogers talks about is respect. And how do you define respect with your patients and clients? And you can raise your hand to talk if you like. Okay, respect is not judging. Okay.
Say the question again, I'm sorry. I got so much going on.
I was wondering what it is, what does the component of respect in client-centered counseling, what does respect mean to you in terms of you providing services to your client?
So basically, the respect part comes from, of course, accepting the person for who they are and where they are at that particular time in their life, and of course, not being judgmental about their current situation or their past.
Very good. Thank you. Thanks, Veronica. Nice to see you. Bella?
So I work in the school setting, and a lot of my students, they experience a lot of disrespect, whether it be at home or at school. And I think a big thing that comes from that is their lack of autonomy and their lack of, independent decision making. And so in our sessions, respect really looks like treating them like a person. I don't know how to say it, like
Oh, no, that's good.
letting them know that their feelings are real. And I think someone just said validating feelings. That's exactly what I'm thinking of, and letting them know that what they're feeling is totally valid, and that they're able to feel what they're feeling and vent if they need to, and feel frustrated if they need to. And I think that's kind of what it looks like there for me.
Yeah, for sure. Definitely agree with you with that. And I think you really built up on what Veronica was saying in terms of that acceptance piece, understanding that this is where they're at, and you can acknowledge that and respect it. John?
I guess respect goes back to the question that you asked in the very beginning in your slide. What do center person means to you? So to me in this field, respect means is allowing that person to have a voice, right? Allowing them to come to the table. To me, center person is allowing that person to actually help write their own treatment. It's not like 10 or 20 years before when you tell them this is what you need to do in treatment to be successful. More is like, you're gonna tell me what you need to be successful, if that makes sense.
No, it makes perfect sense. Thank you. And so, and it really speaks to, so my own personal, but from professional experience, is that respect is everything that you folks have mentioned. See, acceptance is the biggest part of it. Respect is not just not being rude, because that's traditionally that's what the kind of word kind of brings up. Okay, so don't be rude, be nice, be courteous to people. Well, respect is a lot more, particularly in the context of what we do, working with clients and patients. It's really about understanding who they are and incorporating those perspectives. So everything that you folks just said, incorporating those perspectives, that's respect, is we integrate those values, those belief systems into the process to help them. And so that's part of the respect. And so I really appreciate that Carl Rogers, thanks everyone, that Carl Rogers had included that third component about acceptance and unconditional positive regard. And so, and then also when Veronica had mentioned about, when we accept somebody where they are, we're really meeting them where they are. And other folks have mentioned that. It's being able to try to listen to you and try to work with you, from your perspective. And so, and I think it was John just mentioned something about not necessarily us leading the way or directing the way. And so we're going to unpack this just a little bit more. So Carl Rogers started this philosophy a long time ago. And terminology has changed over time, but the main idea is still relevant. It's still one of the things that we are so we try to put so much energy on, and we try to be very committed and intentional about, because it's not something that you kind of do just in hindsight because you have a wonderful personality, which you already have. That's, that kind of is part of what you bring to the table when you come to your work. But it's also about an intentional process where we keep ourselves kind of out of the way and keep the focus on the other person. And so, let me see. And so when working in behavioral health and social care, tailoring your approach to an individual's needs and wishes is essential. And you mentioned a lot of that. You mentioned a lot of that in what you put in the chat box and what was mentioned, or what you verbally added to in the dialogue. And so being able to understand who they are, because if we're going to integrate or accept someone where they're at, that means we have to understand what their perspective is. In order to understand their perspective, we have to elicit. In order to integrate it, we have to hear it and then understand how it speaks individually to that person. And that's what we want to incorporate in our interactions and in our supports. And so benefits of person-centered care include, enhanced self-awareness. This is something that happens for individuals when you are centered on them. And so the idea is that it helps individuals, it helps your patients and clients to explore their own strengths, their thoughts, their emotions, and be able to feel comfortable enough to share with us. And so it leads the provider to better understand the individual and what are the pushes and pulls in that person's life, and what may be barriers, what may be strengths, what can help them achieve their need or the goal that they're trying to achieve with our help. And so it promotes self-acceptance in their part and also their own personal growth. Because part of what we like to do is when we do help folks access certain services to be able to impact, say, I'm going to say in a general way, their quality of life, to address their substance use disorders, or their substance misuse, or maybe mental health or some other psychosocial issue. Maybe it's about prevention and recovery. The whole idea behind that is to help folks be empowered to be able to do it for themselves. And so it has that opportunity to increase empowerment. It's because we're going to help elicit their strengths so they can use it in their own favor. And also, if you can do that, one of the things that we've been learning about is that when we elicit from the other individual their perspectives and their strengths, that is, being present for another individual helps to build that connection with the other person. You folks have put in the chat box the connection piece, that alliance, that therapeutic alliance is really important. That's usually identified as one of the critical components of successful outcomes. And so improved outcomes kind of helps from that. The person-centered approach uses a really strong emphasis on being able to have a trusting and supportive environment, not just physically, but cognitively, how you engage the other individual. And these can help improve those outcomes and help also, the individual to feel comfortable to be able to openly share with us the different challenges and the different ideas that can help us either help or identify maybe risk factors, or help identify support systems that can help them in their process. And so the whole thing about it is to tailor the support to meet their needs and goals and their unique factors. We want to ensure that we improve substance use, mental health outcomes, prevention, support. Part of this is to help folks maybe eventually lead to how to reduce symptoms or mitigate symptoms of mental health or trauma, stress, anxiety, depression. We want to be able to increase their self-esteem, empower them in ways so they can be for self-efficacy, and really their overall well-being. Why would directive not be part of person-centered care?
Because it's telling a patient what to do. I mean, basically, because if it's patient-centered, it's not about me telling them what to do. It's a fiduciary process. We're working together. So if I'm giving a directive, it doesn't mean that the patient is actually going to follow it, because it could be out of their realm to do. So I'm not giving directives in the sense of that way. It's something that's being agreed upon, something that they are able to do.
Yeah. So it sounds like you're saying it's also kind of speaking to that they are the experts into their capacities and what's reality for them. Thanks, Veronica. Patrice, I'm sorry.
It's okay. Directing that to, for me, I worked with domestic violence and sexual assault victims at one point in time. So being able to empower a victim to get back to being self-sufficient, directing them to do so, it would trigger them, because in that time they would feel like you were beating down on them or making them feel like they aren't where they should be on your time. So directing them to do something and they're not ready for it or prepared for it can trigger and resort back to, you know, either being bullied or abused or unheard. Like Bella said, in some of the kids' cases in her school, if you're telling a child like you don't know what's going on because you're younger, you don't understand, and things like that, it'll trigger somebody to go back to, you know, feeling like they're abused in some sort of form.
Thank you. You know what's interesting when with some of you folks who are working with youth, they're already used to adults talking at them. We would benefit if we talked with them. And so I appreciate what you and Bella were saying, particularly when it comes to the community that you're working with. And there is a part of this person-centered care. There's just a part of whenever we've done work, and the research has shown this for decades, is that we have a wonderful array of expertise. But when we tell someone what to do, even if it sounds like a good idea when they're in your office, the reality of their lives kind of comes into play once they leave that office. And so what may sound like a good idea there may not be a realistic idea or a realistic concept, you know, once they leave your office. And a lot of the research has shown that commitment to follow through with something typically comes from when the idea comes from the individual. And so we have opportunities for that. And so allowing the person to lead is a really big part of it. And let me say, people in some circumstances often have their autonomy stripped away. So we emphasize putting that power back in their hands. I think that's so well put. Thank you. And if a patient has demand avoidance, this would have the exact opposite effect. Yeah, isn't that interesting? You know, there was a time when we used to say, so what if somebody's kind of somewhat ambivalent? How many folks know about am I here? Right? Someone's kind of ambivalent, kind of push them in a certain way, you may most likely kind of concretize, their ambivalence, if you push them in a certain way. And so I used to think back, there was a time that folks used to think that if you want someone to do something, don't tell them what to do or tell them the opposite. And we used to say that not very professionally. We used to say that about youth. We used to say that about our kids. And we've learned over time, and we've learned through education, through the clinical protocols and all the other research that has come out, that that's not true. People can work and understand a lot of different concepts. It's a matter of speaking with the individual and gaining from them what's important to them and working from that perspective. And so I think that's so important when we talk with people instead of at them. We're thinking about how we can put that person first. So it means that we want to collaborate with these individuals who come in for care or to access care or even just to ask questions. We want to be able to partner with these community members, not to be the authoritative person. Those dynamics that tend to happen, and this is often the experience of many persons who do come in to access our care. Other social service type of resources may be very directive. That might be what they're used to. But when it comes to the work that we're trying to provide in any one of the disciplines that we work in, we know that the most effective means is to be able to collaborate with that individual, to kind of partner off. And so those dynamics between the providers being the person of authority and the person that can get resources, the person that can help that person meet their needs. And so you really want to kind of balance that out. And so in that way, you're in a better position, and they are in a more receptive position or responsive position to be able to incorporate, what you both agree upon will help them to heal or get better. And so it's very individualized. And so it's coordinated, but really according to their needs. It's a really different, it's a different situation, for instance. Let me just say this. It's a different situation. So many times, like when we think about what treatment does traditionally, and this is when I used to work in treatment, what used to happen is our clients would come in and they have an array of different evaluations they have to do in the beginning, and then that treatment plan ends up looking like, okay, This is where we're going to send them. We're going to send them to OSHA. We're going to send them to these support groups. We're going to have a one-on-one counseling here once, at this day of the week. And we would order, and those plans were typically done in a way where the clients would fit the structured programs that the organization already had. So we're trying to do this a little different. We're trying to make sure that those opportunities that the organization has is tailored to meet their needs, not put that person into the place. It's almost like taking, a square peg and putting it in a round hole. We're not going to make the client, we shouldn't be taking the client and putting them in the organization and just connect them to all these other services. We want those services to be specifically tailored to that person's need. It should not look different. It should not look the same as other clients. And so it shouldn't be the same process. And there was a time where it was very, very similar. The process was very similar, and it looked, and different treatment plans or service plans will look very similar to each other. So individual outcomes were not necessarily as effective as they needed to be. And so person-centered care is really part of it. And Carl Rogers, when he first came up with that concept and that philosophy, and it started to be applied not just in the therapeutic, say in the mental health realm, but we started to apply it in other disciplines. It started to show successful outcomes. And so we want to show that we want to speak to person-centered care as something that a philosophy and approach that recognizes that the capacities of people with substance misuse or substance use disorder can actually actively participate in improving their own health and increase treatment adherence. One of the examples that we know this works, where folks who may be in a very compromised point in their life when they're accessing services for us, we've turned, if you remember back decades ago, when the HIV epidemic was the AIDS epidemic, and going into and when the treatment started to become much more effective, and over some time, one of the things we saw is that HIV infections, hepatitis C infections were very, very high because of sharing needles, or other paraphernalia. And so the injection drug use was a real big problem for a while. One of the things that research started to find, and where harm reduction came from, actually came a lot from the community members themselves. There were individuals that learned how to take care of themselves and not get themselves, and not actually acquire an infection behind sharing needles and other paraphernalia. And they could actively use and still not get sick and not get ill and not get infected. And so we know that people, even though their mental capacities, may be somewhat, would be impacted by either mental health and substance use, because we know what happens with the brain, it gets rewired and all kinds of other things. But even at that point, individuals can actually learn to take care of themselves. So we know that the capacities are there, that the strengths are there. So being able for us to remember that people have those strengths and capacities gives us an opportunity. It's a lot easier for us to be able to access strengths as opposed to kind of put things in place that may or may not work. And so really working from their perspective can be helpful for us, and you don't even have to work as hard. And so I'm thinking maybe some of the components of person-centered care include certain things that I would like to practice right now. So what I would like to do is ask everyone to kind of go in maybe a breakout room. And we are going to pair you up with someone else. And this is the only thing I'm going to ask you to do. I'd like you to think about maybe sharing for 5 minutes. I would like one person to be a speaker, the other person a listener, and then we'll switch off after 5 minutes. I'd like you to think about something you don't mind sharing, something not intrusive, something not too intimate, which you're uncomfortable. Maybe it's something that you wanted to do, been trying to do, but you haven't done it. It's taking a long time before you actually putting the effort in. Maybe it's something, or maybe something absolutely wonderful that you are looking forward to, something that stands out in your life. And I'd like you kind of to talk about it for 5 minutes, something you don't mind sharing with another individual. Now that is for and that's really for the person who's going to speak. So it's, you can think about something that you wanted to change or haven't done yet. It could be something you want to achieve, haven't gotten started, something you deal with regularly that might be stressful. So any one of those things. Something that is not a problem for you to share in case we want to share with larger groups. And so all you have to do is think about that now, and then 5 minutes for you to talk about it. At the same time, the other person that you're paired with is going to be listening to you. Now, the other person who's listening is going, I see your hand, Rafaelina, just 1 second. The other person that's listening is going to do exactly that, exactly what the title says. The person who's listening is not allowed to say anything, no comments, no prompts, like, okay, none of that. You can use appropriate eye contact, and nodding is okay, to show that you're paying attention, but no words, just listening. Okay, Rafaelina, hi.
Hi. How about if I don't feel comfortable sharing stuff on my personal life?
No, what I'm suggesting is something that you are comfortable sharing, right? Or something happy that you're looking forward to, something that's not too intimate, not too personal. Would that be okay?
Not really, though.
Okay, then don't worry, don't participate in it. You don't have to. Absolutely, nobody absolutely has to.
Okay.
And I got plenty of things that I can share too. So,
Okay. Thank you.
All right. So you may be paired up with someone who may be sharing their situation, and all you have to do is listen. Okay. All right. So
Okay.
you don't
Thank you.
all right. Okay, we can do it like that. So a person who's speaking is just share a situation. Maybe you just went to a baby shower, had a great time, or maybe you just like how frustrating it was to go to catch a connecting flight and get there just as the door closed. Whatever situation it is, it doesn't have to be anything that deep. So do that, and then the other person just listens, says nothing. Maybe not ahead, but don't say anything. And then in 5 minutes, we'll remind you and we'll switch off. Is that clear for everybody? Fabulous. Excellent. All right. So this is, okay, Clyde, if we're ready, we can do it now. Awesome. Clyde is always ready. I'll see you in 10 minutes. So let me ask you first. Let me ask everyone first about what it felt like. Okay, not for the speaker. So hopefully everybody was, sharing something that wasn't too deep. We can talk about my chocolate issues and my knee another time. That's what I shared about. But for the listener, and this is for the person who is listening, everyone who shared, thank you for taking a chance to just sharing whatever you did. For those who were listening, when you were the listener, so can you, and this is what I really want to get to, because in order to do person-centered care, active listening is really important. Without active listening, it's like things kind of like go this way. Not intentionally, it just happens that way. Cognitively, we are not designed in such a way that everything that you say, if I'm not present, I'm gonna internalize it. It might come in subconsciously, but it won't necessarily be accessible consciously. And so I'm very curious to know what kind of situation was it? Were you able to listen and hear what the person had to say? Did you have a hard time focusing? How was it for you? And that's really what I'm talking about. And seeing that this is not an exact science, and we're not here with patients or clients, so hopefully you feel free enough to talk about that. So, so let me see. So I saw Nancy, and then Angel, and then Patrice. Nancy, go ahead.
Hi, so as the listener, I was able to connect with her and be in her shoes. I think it was easier because it was like a one-on-one, but I also spoke first. So then I had the opportunity to listen second. But I felt connected to her, and I got what she was saying.
Okay.
I kind of wanted to respond, but I knew that the rules was don't say anything. So I was like, keep my mouth shut.
Okay. So you didn't talk?
Not when I wasn't supposed to, no.
Okay.
No,
Okay.
but I was acknowledging her by nodding my.
And that's fine. And that's fine, because I suggest at least do that, but I wonder, you did mention that it was a little uncomfortable not being able to
No,
respond.
I didn't feel it was
Was it?
uncomfortable. No, I
What was
felt fine
what
with
was
her,
the
and
word?
I felt connected with her.
Okay.
I
What was
felt
the
like,
word that you just used?
well, I don't remember.
That it
No.
felt a little different that you wasn't
Oh,
responsive.
I felt because it was more one-on-one, we were
Mhm.
connected in that room and it was just the two of us.
Mhm.
I took in what she was saying. Like I was there, I was present. I wasn't distracted. No, it was good because I was just focused in on what she was saying.
Very good.
Mhm.
Okay.
No, it was good.
Wonderful. Thank you, Nancy.
Thank you.
Hey, Patrice, how was it for you to be the listener?
It was a little challenging, all because I like to I believe that if I respond with, oh, okay, well, why'd you feel that way? Like the question thing, because like I'm always wanting to get somebody to elaborate a little bit more. But it was easy, all because it was just her and I in the room. So I can sit and listen to exactly what she was going through and how she felt, and I was able to understand and sympathize with what she was, going through and having to deal with. And the connection was really really good. At the same time, helping me, be able to listen to exactly how she felt and what her frustrations were, her anxieties, and all the questions that she had pertaining to what she was going through. So that was like it was like, oh my goodness, I could say something and I'm like, so I had to like nod my head, which is challenging just to be active listener, all because I'm like one of those people who always want to help and come up with suggestions for people to try to,
Mhm.
work through what they're going through. So yeah, but it was really, really nice.
Okay. So, so mostly pros, but there's a couple of cons in there. So, okay.
Yeah.
All right. Very good. Thank you, Patrice. So your energy comes out. Just like Nancy, like we feeling the connection. I'm hearing that word connection. That's great. And we'll talk a little bit more about what you shared. Bella,
Hi.
how was it?
It was really good. I really enjoyed it. I think silence is a tool that I've always found to be very, very valuable in therapy. It's something I use a lot with students, especially for kids, because when you're quiet, they have to keep thinking. And then they kind of, and this is what I felt like happened here is I'm more of just maybe a mirror is the word for it, and they're able to tease it apart with themselves because really they are the expert in what they're talking about. So I think silence is really wonderful with the occasional nonverbal nod at a very key moment to acknowledge and kind of give like affirmation of what they're saying. And so there was like a moment, I think, with my partner where I nodded at something she said when I saw her pause. And then she kind of felt like permission, like, that's okay. Like what you said was okay and you can keep going. And so that's kind of what I felt.
Very good. Very good. Thank you. Angel Diaz, would you like to share with the group? Because your hand is up. I'm not sure if you're just responding to my last question. All right, so let me just do this. All right. So I see a lot of chatter in the chat box. So, all right, I wonder if active listening that just involves the head nods and eye contact takes the pressure off the therapist. The focus just listening instead of the therapist thinking of response and the right thing to say. So that's really nice. So I saw a lot of other comments and I really would like to speak to that. What I'd like to know is was it easy for everyone to actually be in the moment and pay attention? I know I heard that because you were in a one-on-one situation, it wasn't too difficult for those who shared. Here you are, you're in a little box. Let's just say it was me. I'm in a little box, it's just us, so nothing else supposedly exists. In real life, in your own setting, that's not necessarily the same dynamics. So that might be a little different. But even like that Patrice was sharing is like, she's used to kind of coming out and trying to Yeah, like, let me, if I dare say kind of problem solve, if that's okay for me to say, all right. So kind of problem solve. And that's pretty much what many of us tend to do. But I love what Samantha had put in, the focus shifts to just listening instead of thinking of a response and what to say right away. And that's what active listening is about. What makes it challenging often is the maybe the fast-paced life that we have inside the world of our profession. Maybe because things have to be done yesterday, maybe because sometimes we have things in our minds that carry us in different directions. What do you think about that? What makes it difficult for us to actually listen to the other person? Samantha.
In my opinion, I think it's because, especially being a social worker, we're kind of trained to like fix things, like, you know, so we don't just want to kind of meet the client where they're at and let it be okay that they're not okay. We just want to get them out of that situation and try to fix it. And I think that's the part of the struggle, at least in my experience.
Yeah, very good. Thank you, Samantha. Alice?
I think you said it already. It's the problem solving. I want so badly for them not to. That it was very difficult for me to not talk because they actually said I don't have anything else to say, and we had so much more time. So I I feel like I'm doing a disservice, but I really like hearing what other people would say about the benefits of just keeping your mouth shut. But it doesn't feel like I'm helping. It doesn't feel like I'm helping when I'm just sitting there. But I can intellectually hear that it's better that way. It's hard.
I get it. I can relate to what you're saying. I can relate when I was doing direct services. It's like I want to move the person into kind of let's problem solve, let's get to a solution. And the thing is, I want to do that because I'm feeling for them and I'm letting my emotions are kind of guiding it. And it's like, and I think that's part of the not just the empathy and the compassion and the skill set, but that's that part of us that makes us so good at what we do. It's because we want to help people. It's not easy to do the work that you guys do. Things, it's not the easiest thing to do. And then when you're in your heart of hearts, when you want to help, that kind of gets in the way sometimes. And so, but it's so interesting how valuable active listening is, because in order to be person-centered, you have to get comfortable. And someone said it before, they used it silence. Get comfortable with sitting still, get comfortable with being silent so you can hear. It's not the easiest thing to like be focused and you already have a solution because you have experience. You've helped other people. We're very similar with very similar situations. And it's like sometimes I want to tell myself, and back in the day, and I tell some of my colleagues, it's like, get out of your head. Just get out of your head for a minute, get into their head. But it takes practice. It's very human because the nature of who you are and the nature of your profession. So there are some things. So I was looking at some data that I have, and I found that some folks they captured some anecdotal type of comments from these folks when they were doing an activity, a listening activity. And so I love that Nancy was the first one I was speaking to that, but listening to find connections. And so sometimes your mind thinks, oh, I remember when that happened to me too. Sometimes that's where our minds go. So a patient or a client is sharing something with us and we can relate because we may have had a similar situation. But that means our mind's going there. Does it necessarily come back? Kind of depends on our skill set. Are we able to kind of bring us back to the moment? Listen to find a story of your own to share. Your mind thinks, I can tell her about that time that this, if you're thinking about in a way to kind of promote hope or promote support, that's not a bad thing. But if the person is sharing, then you're no longer absolutely present with that person. This might be something that might happen with folks who have lived experience, because part of what they bring to the skills that they bring to the profession is that they use lived experience accordingly to help support individuals in recovery. And yet still, our minds might get distracted, but do we bring it right back? And so listening to ask a probing question to learn more about the speaker, that's awesome. And it sounds to me like some of you did that because you did have the connection. And it seems like it was from everything that I saw in the chat box, it seemed like some folks were able to like really understand where the other person was coming from. This is the one that most commonly comes up, and some of you spoke to it already, is listening to fix it. Because in our nature, as human beings, we don't like to see other people suffer. We want to help problem solve. And our professions very, when it comes back to like when we initially started to do social work practice and when these other disciplines evolved over time, it was always very many times not just about helping the other individual, helping different community members or the clients, but even our programs are in our organizations kind of pushed us to help get to a particular goal, to achieve a place with a particular client, because that was seen as successful. And that has changed a little bit. So listening to fix it in a way to help us solve a problem, it shows the wonderful side of you. But what happens when we're listening to fix it? What happens when we're listening to fix it? We may not really be listening, or we may stop listening, because we may still hear that that person is talking, but active listening is, what is active listening, by the way? How do you define active listening? Samantha?
I would say active listening involves like kind of using all of your sensors to listen to the person, including your nonverbal body language, your eye contact, head nods, like that we just did in that practice. And again, like listening to listen.
Yeah, thank you, Samantha. And if I may, I'm just going to add one little thing to that. So we listening, we don't have to take it like just in a templated approach of very little. We want to broaden that. Yes, we want to hear what the person is saying, but we want to hear the tone. We want to hear sometimes what's not being said. You can't do that if you're not completely present. And you can do that the best of your ability. It doesn't mean that everybody has to be at 100% all the time. That would be very unrealistic, considering what our worlds as professionals look like. But you could definitely be present with an individual, and to the point where you can hear the tones, maybe some of the context that seems to be alluded to, but it's not necessarily specifically spoken to. That's active listening, and not necessarily thinking about, okay, I have this, I know what I could do to help this individual, but then all of a sudden it's like you're kind of turning off. You're just waiting for them to speak, to finish speaking, so you're not rude, so you can provide them with a solution. And that's not easy to do, but it is possible. Because I know different things are really prompting your attention, and different things you're gonna be required to do throughout your day. But that individual at that moment, when they have your attention, needs 110% of you. 110% of you, because sometimes an individual is not even aware that certain things are really going on with them, and you're the one that is able to listen to it and really respond to it. And so I really do like what everybody's saying is like listening without a response, but it's engaged and focused listening. I like that, Lydia. Thank you. So it's nonverbal, eye language, and eye contact. It's all of that. It's really being so focused that you can hear the words and see what's behind the words. You don't have to be clairvoyant, but sometimes when certain comments are being said, there's a picture, there's a situation that's started to be highlighted, and you can also pick up on tones that you can sense frustration, happiness, depression, sadness, different things like that. So that's part of active listening. And in order to do that, being present with the individual. And so I thought it was really interesting when we caught some of this, and sometimes listening and thinking about how their story helps you better in your own life certainly changes the direction of our focus. We really should be focused on the individual. So it's really more about how do we practice that so we can get into the habit of being more focused on the individual than not. And so thinking about our own personal experience, what I want to ask you is what would be an appropriate way for someone to listen when we go through something, when you go through something? Think about a personal experience where where you felt you were heard. Who was that person who did it for you? And you don't have to say a name or anything like that, and explain what they did to convey to you that they were present with you. For instance, in your professional or your personal life, I'll give you my example. There is an individual that I can ask, when I go through certain things. I know a lot of folks. I'm very, 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 very fortunate. I have folks in my life, and to different degrees, and it's kind of really great. I love that. Everybody's a world unto themselves, and I think that is amazing. Yet there's less than a handful of folks that I might go to if I am in a very vulnerable place and very challenged with particular stressors. It could be a professional, it could be somebody personal, in my personal world or my social circle, but I do have a person that I do go to. And there are reasons why I go to this person. There's like 3 of them, but this one person is my first go-to. And what are the reasons that you would go to one individual when you are going through very unique times, whether it's professional or personal? I mean, because I know we have supervisors, clinical supervisors, but let me put that on the shelf. If you were to go to somebody in your personal life, why is it that you will go to that person? What is it about that person that allows you to think of them when you're going through something? So without identifying any names or anything, what is it that makes you want to connect with that individual or know that you can go to that person? Okay, I had a friend who listened well, body language showed interest and acceptance. They didn't interrupt, encouraged me with open-ended questions. Okay, what else? What else is important to you? Okay, listening, objectivity, well-thought responses, non-judgmental, trusting, knowing that there's no judgment for learning. Nice, validation. Anything else you would, and did you folks want to add? Oh, okay, feedback is important to you. Okay. Emotional connection. Anything else that anybody want to verbally add? Okay, so here's what I'm gonna answer. When you think about one of the things that we don't want to miss at any point when we're working with someone is that many times the folks that come to us, they're coming to us because they have needs. And if they could get their needs met on their own without having to seek help from another individual, they're more likely to do that. Many times when they do try to do that, their experiences are not the best. And many times their experiences are the very reason why they don't seek help. When we think about people with substance related issues, or say somebody's coming in for a medical issue and the substance use is brought up, and people don't even understand that person may not even understand that they may be misusing, and potentially causing themselves harm. How do you have that conversation with someone with just anybody, or with that kind of conversation? Would that mean that that person who wants to bring it up, the provider who wants to bring up that conversation, would have to have a particular way to engage the individual to help the person feel safe? If I were to go to somebody, I would be somebody that I think I would feel safe with. Safe meaning you're not going to stop me from talking, interject, and tell me what my solution is before I finish even talking. Wouldn't that be nice? Well, and it's not that you don't have the expertise, it's just that, what is it? Some of us would like to be heard. It's just the idea of being heard. Just as important as it is to us as professionals, and we know this, it's just as important, especially to individuals with an array of different issues that they may present with. And so the context of their life usually looks different than the context of our lives, and we're in a position to support and help. And it has a lot to do with active listening. And so in order to listen, we have to listen in order to understand who the person is. How can we help if we don't know what's going on? How can we use their resources if we don't know what those are? How can we do that if they don't even feel safe and comfortable speaking with us? So this is all part of the active listening piece. And so the idea here is to understand, I'm going to go through a few slides. Yeah, sometimes one is not looking for advice or fix, but just to be heard. And it's true, you know, there are times where there's some folks that might have to say, listen, I just need a soundboard. Please don't tell me what I, don't tell me what I already know. I just want you to listen. Can you do that? We may not be able to go to every provider and expect that, you know? And so think about how the community members who do come to us, who do take a chance with us. And if we dismiss that opportunity, sometimes we can't get it back. We typically can, but many times we can't get it back. Those are missed opportunities. That's not something we want to initiate. And so it's really important to understand how we present information. It doesn't mean that you can't use your expertise, it's how you present it. And we talked about, I spoke that, I mentioned that MI is a really big part of what you or folks have been talking about, and those are skill sets that we're going to think about. Over here, that person who is in your life that you might go to would be somebody who can listen, somebody who's not judgmental, somebody who's willing to wait, just to know, you know, what your needs are. And so it is challenging at times to listen because we have so many things that are in our heads and that are pulling us in different ways. Especially we have someone who's speaking is speaking about something very intimate, and you know you have an upcoming appointment that you have to meet, or that you have this case conference that you have to do, or you have to, or a myriad of other things. The idea here is to understand where the person is coming from and what their motivation is. So think about this. If we start to talk, so active listening is one part of it. How else do we learn about who a person is and their values? I'm not necessarily speaking to a session where I get to have a 45-minute session with someone so I can learn all about their history and they can give me their family history and their family background. It means that in the moment I can be attentive and be able to start to listen what seems to be the most important things for them and start to learn how to identify those things so I can incorporate that. So sometimes with understanding also comes the opportunities for motivation. So if something's important for us and if something is important for us and important to us, we'll be able to do it. And so that's that whole thing that we said before about, you know, who directs the conversation. And so if the person is coming up with something that's important to them and it's about something important to them, and it's likely to, you know, they're likely to continue in the conversation. If somebody tells us something that we should do and we don't agree, we're not going to do it. It's the commitment piece that's really huge. And so what we want to be able to understand is how do we go ahead and work with that? And so if we're seeking to meet the needs and goals of individuals, then it would help us to learn what's important to them and their perspective. One of the things we talked about was about being person-centered. In other words, in order to be, in what you talked about, what the respect component of the Rogerian theory was, and Vanessa started off on that, and it was about accepting who that individual is. Can't accept the individual if you don't know who they are. So you have to actively listen to who they are, what's their values, and be able to start to understand how do you meet them where they're at? How do you understand their world so you can help support them where they're at? Because it's really about their capacities and their strengths. And that's what this is really speaking to. And so person-centered elements is really about focus on the whole person, not specifically focus on fixing the problem. The problem fixing is something, remember, we're supposed to be collaborating and partnering up with them. And so we don't want to fix the problems. We want to partner with them and walk with them through their process. So it's also a strength-based approach because really we want to help identify what are the resources that the individual has, knowledge, skill sets, opportunities in their world, within their capacities that can help support them in how they can how we can help them meet their needs. And so we're going to talk about the core skills of eliciting, learning, and collaborating, supporting potential solutions, but in a collaborative manner. And so your expertise will come true. I think sometimes we lose, for a lot of different reasons, we might not be as patient with any given individual because we do want to resolve, but we could trust the dynamics after you build a rapport with an individual, that you can use your expertise according to the needs of that individual once they start to share with you in their safe environment, you know, what are the things that are they're stressing, what is stressing them or what they're going through and what their needs are and how their value system impacts, and be able to do exactly that, integrate that. That way, that person is the one who's leading the conversation in their process, and you can best support their recovery and wellness process. So we go to active listening, building rapport and trust, which is very familiar to all of us. Empathy is extremely important. This is kind of like what we bring to the table in this kind of work when we're working in the people field, you know, by providing empathy and unconditional positive regard, providers are able to foster a sense of safety, a sense of acceptance, a sense of validation even. And so that way the individuals are more likely to express themselves more with more transparency and be more themselves with us because they're feeling safe enough to do that. And so then together you can partner off with that goal setting. The other piece that I want to mention, the person-centered care is about, it's about the autonomy. It really depends on what that person is willing to do or wants to do and how they want to do it. We can tell everybody a whole bunch of different things and a whole bunch of different ways, but that person needs to want to do it. That commitment to follow through is the very thing that's going to help them feel successful. Our expertise is not exactly what's going to help them feel successful, it's how we can use that to help support them. So, any comments, any questions right now? Okay, so I want to come back and talk about a couple more things and then come back about, especially, and then come back and talk about the culture of humility. So I forgot to mention earlier, this is because we're here so long, we can take a 15-minute break. Are you okay with that? Unless you really want to pummel through. I'm okay with doing that. Okay, everybody just said yes, almost all at the same time. Okay, all right. It's 11:26 Eastern time, my clock. Just add 15 minutes to that and come back, or 15 minutes from whatever time is on your watch, and we'll come right back after that. Don't log off, but you can, take off the video for the moment. Hey everyone, welcome back. Refresh. Very good. Okay. So let's just continue the conversation. So this is, I'm really interested to hear the cultural piece from you folks. And so there's a reason why we're matching the cultural humility piece with the person-centered care. And so I'm going to go to here. In our practice, one of the benefits of having strength-based or best practices, whether they're evidence-based or promising practice, it's that they tend to align with one another. It would be extremely difficult to have be funded to provide services in a specific manner, and then you're still providing other services as well, and they have to be, and they're completely, they're delivered in a very completely different manner. They need to be aligned. The concepts need to be foundational to the different strategies and practices that you have. And so recognizing alignment is really important here. So person-centered care means that the individual's values, and this is what you folks spoke to, individuals' values and preferences are elicited. Once they're expressed, guide all aspects of their healthcare, supporting their realistic health and life goals or their needs or whatever their the reason they came in for our services are. The other thing that's very similar here is when we think about culturally responsive services are also those that are respectful of and relevant to the beliefs, practices, cultural and linguistic needs of diverse communities. So you see a lot of alignment here because we're focused on responding to the individual. We're focused on integrating their perspective, their preferences, their belief system. And so both quote unquote definitions are actually speaking to a very, very similar process. So I'm going to ask you all a question. So because I want to segue now a little bit. I want to ask you folks, so can you share a time, all right, this is a large group question, this is for everybody. Can you share a time when you had to change or the usual way that you do practice, okay? The usual way that you do practice in order to provide services to an individual in a much more culturally and linguistically appropriate way. Is there anything that can stand out? Does it come to mind at any time that you had to kind of change what you typically do in order to meet the needs of that individual in a culturally informed manner? Dana. Hi, Dana. Hi, would you mind sharing with us what that was?
What's up?
Would you mind sharing with us what that is?
Sure. A few years back, I had a client who was Egyptian Coptic. And so I really had no understanding of like what that culture was. She was a residential client with us, and so her family was heavily involved. And I just walked into it with a lot of curiosity. Like, very honestly, I don't know this culture. Can you please explain it to me? I would love to learn more about it. And being able to be open and listen. I attended one of her Coptic church services with her. I spoke with her and her family together to learn more. So it certainly helped me understand her personality and where she was at by understanding what had been going on, like the family dynamic related to the culture.
Okay. All right, so that helped you were you able to meet her needs more specifically?
Absolutely. And
Okay.
it really helped with the therapeutic rapport because I was able to be honest. I'm not going to pretend I know something that I don't know. I'm not going to Google it and come back and act like I already knew this.
Mhm.
I asked her to like really be my teacher and like help me understand all of this. I'd love to learn more.
That's very good. Thank you. That's certainly coming from the world of asking them what's working for them. Help me understand. It was interesting because I asked the question is like when you had to change practice, when you had to do something a little different, So and I don't like to make assumptions. So Dana, so that wasn't the usual way that you engage with your client, most of your clients.
No, at that point, in my work experience, I hadn't had somebody with a culture that I didn't have at least a minimal understanding of. And so starting at a baseline of 0 and really having to learn a lot about where this young lady was coming from. Whereas at that point, the cultures that I'd come in contact with, I at least had some understanding of.
Very good. Thank you so much for that.
Yeah.
So anyone else has an experience where you had to kind of change the way you usually, did your work and address your patient or your clients? Samantha, go ahead.
A few years back, I was also working in residential and I would bring the kids home to visit their family. And we were taught to not use anything in the person's home, bathroom, food, water. But it was my client's birthday and the mom wanted me to have a piece of birthday cake. She wanted me to be a part of the celebration since I was a part of her daughter's life. And I realized that was really important to her. So I participated in that.
Okay, thank you. Yeah, that's true. There's so many times now we have agency protocols. Agency protocols we can't do, and they're valid reasons for that and all that. But thank you for that. Jonathan said had to assist a hearing impaired client with transportation somewhere, so I was trying to learn it, remember enough sign language to be able to communicate with them. That's very proactive in their regard. Thank you, Jonathan. Anyone else would like to kind of give an example of maybe a situation that happened for that? Okay, I'm going to include an example just to add to what these ladies added, shared here. So I was working and I actually left treatment for a little while to go to a work in prevention, which was kind of weird. I used to hear my colleagues go from prevention to get to treatment. I went from treatment to prevention. So a whole different mindset, a heck of a learning curve at first. But after a while, I started getting the hang of it. And I remember one time, I was the organization was small at the time. And so I was like the designated Spanish speaking provider. So I automatically was given all the individuals that supposedly spoke Spanish as their preferred language, and they were sent to me. It just happened automatically. And so, there were a lot of learning opportunities here. What ended up happening with me is that I was used to engaging initially in rapport. Hello, my name is Diane Padilla or Diana Padilla with a, like almost like articulating almost with the Spanish, with the Spanish articulation to let them know that I also speak the other language. And I would ask them if it's okay to shake their hands, and I asked them how they would like to be addressed. And that was my usual all the time. Now, what I had to change was that the manner I started to engage them, we had to do part of the protocols included doing an assessment, and in prevention, the assessment back then was a very lengthy one, asking very intimate questions. And of course the other the graphic type stuff, which is usually the easiest things to ask. And so when I first started to engage the gentleman, and his first language was Spanish because I had asked him, that was fine when we were asking about address, and we were asking about how long, what his phone number is, those logistical questions. When I started to ask intimate questions, and this had to do with HIV and hepatitis C prevention at that time, and you're asking those kinds of questions. So it starts at the assessment includes the risk factors, how many partners, with or without condoms, all that kind of stuff. The gentleman happened to be much older than I. He was a Hispanic individual whose first language, like I said, was Spanish, and although I had said I have to ask these other questions, when we met for the second time, when I have to ask these other type of questions, I want to be transparent. So he had flatly refused. And he let me know in no uncertain terms that I remind him of his daughter. And so I had to say, that was a while ago. I was a lot younger. And so at that time, and then he was saying, I am uncomfortable sharing with you any kind of details like that. And I totally get that. Now, there was this idea that because the individual was from a particular community that I identify with, that we would be the best match. What I had to do was not to try to lose my client. It was a matter of me having to step back and go back to the supervising people and let them know I am not the best match for this person. I did speak to him in Spanish. I said, it's okay. I don't have to ask you these questions. If you're comfortable, would you be all right if I have another gentleman ask you? And of course, he was okay. Unfortunately, I didn't have another gentleman who was Hispanic and spoke Spanish, but he was comfortable with the gentleman, African-American gentleman, and with the English, and we ended up matching with somebody else. So what I usually did, I always engage my clients to try to connect with them from where they're at. At least that's what I tried to do, because I started to learn in the earlier days of my career. I started to I went through my own little pitfalls to understand that. And then with this individual, I had to literally step back. And I had to say, okay, we need to do another kind of matching. And the gentleman ended up being a client of ours with the other gentleman. And sometimes they use the phone translation services. And so what was interesting is that I had to kind of change the dynamics according to the person's need at that moment. It wasn't the usual way I did business, because usually I engage folks. I had to know that, okay, I'm not meeting that person's needs, and let me take a step back. I didn't take it personal. I just needed to know, okay, how to best meet that person's need. And then on top of that, I was able to speak to the decision makers in the agency at that time and say, we're going to have to kind of think about this a little differently, because in order to tailor services to any given individual, it could have been him, it could have been somebody from South Africa, it could have been someone from Guyana, it could have been someone from Haiti, it could have been someone from anywhere. It could have been the same situation with someone else. It's like, so we can't just match people automatically like that, like think it's going to work well. Sometimes we have to change up how we do it. So how do we do that? We have to tailor our approaches. So we had to address it not just as an individual provider, but also from an organizational perspective. So we learned a lot from that. And it provided us a little bit of growth behind just that one situation. And so every once in a while, you have to kind of change up. And we really should be doing that for every given individual. And within our own resources. And we can do that. That's really about culturally informed practice, about tailoring that process. Part of that was talking to the gentleman, understanding how he felt, his values, his beliefs, and incorporating that. Respecting that means I acknowledged and worked with it. Didn't mean we stopped giving them services, that we weren't going to do that. It meant that we were going to do it a little differently to meet his needs. And that's the whole and that was the whole idea. And that's what it translated. That's what it looked like. So I appreciate the situations that you all shared. So thinking about that, that's the part that I'm thinking about, the alignment. in terms of person-centered care and culturally responsive services are those that are tailoring to the needs of that individual. And so what we want to think about is that we know we're going to bring empathy. We know we need to listen with an open mind and listen without judgment and seek more information. We did that. But we also want to understand, some of the barriers into, let me move from there. Listening with empathy. Let me just move from there and I'll come back to that. I want to go into the culture of humility. So in culture of humility, one of the things that we have to work with, and it can look different, even if it almost looks the same on every given in person, people who have substance misuse, substance use disorders, different traumas or stressors. And when we think about trauma, not everybody knows that they've had traumatic issues or they have any issues that might be affecting them in their present day. That's why we get the training, so we are more aware and understand how to work around that, how to be more informed and more preventive. So people who have all these different issues have a complex, a lot of sometimes complicated psychosocial issues that they present with, even though there's one need that they may identify that they come to our agency for. And so the idea is we have to use a tailored approach. So culture of humility. Matter of fact, let me come back here. So how do you define culture of humility? Any idea? All right. Thumbs up if you've heard it before. You've heard of the term. Okay. So we're not too clear on what it is. Okay, that's good. Alice?
I was going to say it's the opposite of ethnocentrism. It's a way of decentering your own culture and possibly centering that person's culture, at least in your conversation and in how you care for them.
Yes, that's definitely a huge component of that. Thank you. Anyone else wants to add? I mean, in the literal sense, there's some clues there, but there's a little bit more than that, as Alice spoke to. Yes, Samantha.
I think culture of humility has some kind of component of self-awareness of the worker and how their culture might kind of have biases towards the person receiving the services culture, just kind of that continued growth and self-awareness of one's own culture, how it shows up.
Okay, that's another part of that part as well. And I like awareness because it begins us in that process. It's not where we want to stay, but it is a process. I mean, you have to recognize that there's differences before you can do anything about it. And so it's, not everybody's the same. And we've always said that no two clients are the same, but no two people are ever the same, So respecting other cultures, taking them into account, telling the truth you don't understand and showing humility. Yeah, open, receptive to those who are different from you. Okay. That's all part of it. Yes. The other thing is about recognizing the power privilege dynamics. How many times have we had individuals come in and access services with us, and they come with the past experiences, the experiences that they've had in different places, whether it's the medical field, whether it's other social resources in the area, and they're not necessarily are engaged in a way where they're partnered, where they're spoken with. We talked about earlier about speaking at people instead of about speaking with people as opposed to speaking at people or telling people what to do. It's really about engaging them in a conversation. The person-centered process engages them in a conversation. That's critical. If you can't engage them in a conversation and you can't actively listen, if you're too busy kind of talking over someone and too busy knowing, well, this is the issue that was identified and you have the file and then you already know what you're supposed to do before you speak to the person, that has nothing to do with person-centered care. And you risk outcomes. You risk effective, tailored outcomes for that individual. You also risk losing the person altogether. And so it's not person-centered care. So the culture and humility process as a process really gives us these steps that we can build upon, that we can use to achieve that person-centered approach. So how do we do that? So the self-reflection piece is pretty important. Incorporating understanding of the culture and relational dynamics and differences. Really appreciate what Dana shared about when she didn't know, she asked, she was asking questions. So she was looking to learn, to be the learner. That how can we help someone unless we understand what works for them? And so develop that self-awareness about your own perspectives. And when you develop that awareness, it's you have a higher likelihood that it won't be you can see the differences and work from the other person's perspective as opposed to yours. Sometimes and I'm gonna use a catchphrase here, it's like when you can develop that self-awareness, you can kind of see yourself coming. And keep yourself out of the trajectory when you're working with your patient and client. Also, sometimes you're able to when you develop awareness, you can also address and identify and address personal bias when they come up. And there are times when that's going to come up. We're in our humanness, it does come up. And we're not in the environment that we live in and we've grown in and we've developed and have existed in all our lives. We have likely been influenced in so many different ways. We may have personal bias. We've got to pay attention to those feelings that we get, those red flags that come up mentally that let us know, you know what, this seems different, and I have to address that. I have to make sure that it's not about me, it's about the other person. So in terms of self-reflection, there's a lot of opportunities here. So you tell me, can you take a time, maybe not every evening, but maybe at the end of the week, how often do you, this is what one of my professors had told me years ago, is you should take time to take a step back and kind of see how your week went. If you have an interaction with a client and there's some kind of uncomfortability that stays with you throughout the day, don't dismiss it because you have a lot of things on your plate. Actually look at that, take that as an opportunity to be able to revisit the situation and see where you could have done better. What were the dynamics? How can you move forward differently? And then you can also think about how can I learn from observing my behavior today? So that's a potential way to do it. So self-reflection, how often do you folks do that? This is actually not a bad idea, especially when it comes to wellness. Does anyone do any kind of self-reflection? It's a really neat way once in a while. It's one of the healthy habits. I self-reflect daily. That's nice. It's such a nice habit because it also helps you. Your own wellness is also part of this self-reflection piece. So knowing where you're at. So if you're in a healthier, more grounded frame of mind, you're better able to support others. So it's also, if you're thinking about that other person, if you're thinking about the community members that you're working with, that is extremely important, because then you also want to make sure that you are in a place that you are if you're not well, if you're feeling frustrated, if you're very weary, if you haven't been sleeping well, if there's a new baby in your life, if there's some issues going on in your life, and all that is further stressing you, you're still going to work, you want to be able to self-reflect and understand, is your value system, is your mindset, is all of that, is that getting intertwined with interactions with the individual and getting to know them? And so it's helpful. You can do it first thing in the morning, you could do it later on at night. The idea is in the mornings, meditation is always mindfulness. Mornings throughout the day can be done, but the self-reflection piece is really for you to be able to visit a situation and kind of look at how you're working with your different clients and seeing how effective you're being, and maybe be able to self-improve in areas. Maybe there are certain things you can do a little better. Maybe there are certain things that you just learned from and say, okay, now that I know that, now that it's worked out with this client here, maybe going forward, I might do different. And that's kind of like what it sounded to me like with Dana, where she had changed the way she worked with a particular client to meet their needs, to help understand what their world looked like so she can better support them. And she was able to use that going forward. And so self-reflection is so effective and so helpful in so many different ways. So that's one of the components of coaching humility. The other thing is you have knowledge, you do have expertise, and that is very much needed. I mean, you folks are not doing the job that you're doing unless you were qualified. And so that's critical to the work that you're doing. But it's really important to understand what what are the common challenges you present with? For instance, if it's substance use related, what are the common substance related issues that are presented within the community? What are the characteristics of the different individuals, whether cultural, whether they're gender wise, what are the different characteristics or belief systems from individuals of the prominent group that you tend to work with? When you're working with a person, it's really about eliciting information so you can understand what their values and belief systems are about. What are the cultural patterns that you might see? Sometimes, so I do a lot of trainings around culture. And then I do have some that are very specific to certain communities. One of the things that can be helpful is to understand that it's not static. That we have collected data and research and done surveys over so long that helps us understand patterns, just like when we collect data around how opioids and other substances are used within across the country or in our region or in our community. We want to understand the patterns so we can better inform how we go forward with a particular individual that might fall within that context. And so, but cultural patterns can help inform us, help us understand, help us anticipate that the responses might be a little different, that maybe we need to elicit information so we can better understand and support. We know that rapport building and engagement is really key to making a connection. We know that active listening is a huge part of it. And so asking an open-ended question so someone can respond back and elaborate is a really great opportunity. So the skills really include exploring and recognizing the importance of how situations are perceived from the other person and addressed from a cultural context. So this piece here, we're still talking about not taking our own expertise forward, but really eliciting from the other individual, what do they think they see? What do they think their situation or their problem is? Why they have their need, and what possibly have they done in the past to address it, just to get some context and some understanding of their situation. Matter of fact, there is in the cultural formulation interview, the CF2, the CF2, which is in part of the DSM-5, was developed years ago in order to help providers and practitioners and clinicians understand how they can use certain cultural informed questions and certain approaches to help gauge the perspectives of the individuals they're working with, so they can incorporate that in the treatment plan, so they can incorporate that in the context of a conversation. And so, and a lot of times what that does is provides us opportunity to identify strengths, within their perspective. And those highlight the values, and those highlight those very aspects that can be reframed to help support someone in their recovery and their wellness process. Another thing they can do is about being able to engage. When we engage, we can't initiate a rapport if certain things are happening or not happening. So how would you, let me stop the share here for a second. When you first initiate conversation with someone, or when you first meet someone, how do you make sure that you have a culturally appropriate, trauma-informed, affirming or inclusive environment? How do you do that? Environment can be physical, environment can also be cognitive. What ideas come up for you? How do you do that in your space? Whether it gets done now or not, just how would you do that? You got a new agency, and you're gonna help cultivate that aspect before services are before we connect people to services. Okay, Samantha.
One thing I do just to make sure my office feels safe for people is I have a little sign that just says, like, that I'm an ally, for the LGBTQ community. So that's just one thing I do that kind of indicates that I'm an ally there. And then also with any kind of decorations I put up, I try to have an awareness of like how that might be perceived by someone who doesn't identify with my culture.
Very good. I like that you take the intentionality of it. Just to take it a step further, how might someone else perceive it? Excellent, thank you. What else? So I'm reading some stuff here. Who else would like to verbally share? Patrice, hi. You're muted, hon.
Sorry. I think it's really important to create spaces for privacy and so that people understand that they can share in, you know, in confidence and in private space, safe space.
So important. Thank you for that. You know, we're all supposed to be very careful around the confidentiality. We're mandated to make sure that we explain that to every person that comes in for services. We don't always think about how that can help create that safe environment and that private space. I'm not in a private, if you don't have so many clients in a private space, how likely they're going to talk about something very intimate like mental health or substance use or any other, you know, some of you folks, you know, who work with the partner violence, around partner violence, or the youth who don't want their peers to know what's going on in them. I mean, we can go in so many different directions with that. It's not just that we check, we tell them confidentiality, you know, because many ages, and then, you know, we make them sign a form. Confidentiality, okay, check. We met our requirements as an organization. I can tell you how many times I could be so frustrated because so many agencies, we do that. We want to make sure we meet our legal requirements, but we're not necessarily helping the community explain to them what confidentiality is and have them explain it back if there's some confusion. Ask them if they understand. That's a good way to help them know. And depending on how you frame it, you can actually help a person understand that the environment is safe and this confidentiality is about them. Totally about them. If a person's not feeling safe, how are they going to share the most intimate details that you need to know so you can support? In some places, providers would just have the person to kind of just speak any question about confidentiality, just kind of assuming that the individual understands it because they have because there's other resources in the community that they access. Everybody doesn't do confidentiality the same way. They just don't. But we never used to look at it as an opportunity to have a conversation, to help an individual know how important it is, how relevant it is for them, how it's all about them and how we can best help them. We don't always think about that. That's a really great opportunity. You know, so I think that's wonderful. So Lydia adds about the decor being simple and doesn't include any religious indicators. Keep smells neutral. Oh, we got right here. Ensure privacy, white noise machines, link with interpreters in the area. Okay, that's a whole list of stuff. One of the things that is interesting, and we didn't always pick up on this, and of course we learned, thank goodness, you know, I know not everybody's as geeky about research as I am. But research can be so informative. So pick and choose what will work for you. And one of the things that we used to see, what we noticed very a while ago when I first got into the field, what I noticed was public hospitals, which was a really important resource and still is for a lot of communities today. Public hospitals have, and I'm talking about New York, so I'm not talking about anywhere else, just in New York, they have certain colors that were not as conducive for someone who may be trauma affected. And trauma in the medical field is not, it's a physical impact, but we're talking about something different here. We're talking about the psychological impact that people may have in certain stressors in their life in whatever situations. And so the colors were not either very triggered hypersensitivity or the very loud colors, or they were really, really dull or reminiscent of other social structures. Have you ever had, I don't know, anybody ever work with the criminal justice system? Okay, so I'm just gonna put it out there. Work with the criminal justice system. You ever had to go do any kind of assessments when you go to a jailhouse, when you go to a precinct, there are certain colors they used to have, and it was reminiscent of that when you went into the hospital, I'm saying, and then some agencies had very similar colors. Sometimes it had to do with a very limited budget. But we started to understand that sometimes it could trigger certain reactions in individuals. So having colors that were more, you know, simple, conducive, more calming. I mean, actually thinking that way was really, really helpful. These days, especially after surviving the pandemic, I think being trauma informed is so important just for everybody, not just for our client community, for all of us. And so we've learned a lot from that. And so that environment that we're trying to speak to here, I also think about I did say inclusive environments. Samantha talked about, I think, was it, you had the colors or certain things? I know we used to have the flag up, or depending on the flag, because the flag has changed, but these days we use the flag with all the rainbow colors and the transgender symbols as well. And so it's very inclusive. It's just a nice way, even if you don't say your pronouns, it's a nice way to show that it's a friendly, safe environment. And let me just tell you why my pronouns say here, and I'm not in the habit of mentioning it. So I have a lot of individuals in my life who I happen to know how are very close to me, who are both professionals and personal, very dear to me in my heart, and who have also told me that they don't necessarily use pronouns. So I said, okay, there's no hard rule about it. I like to make sure that it's there. I like to make sure that it reflects some friendliness. And of course, I'm going to ask you if I'm working with you. I also include, because I happen to have linguistic skills. I'm bilingual in terms of English, Spanish. So one of my pronouns is in Spanish, because if there's a Spanish speaking individual, their first language is Spanish, you can do it if you know French, if you know Swahili, you can do it from any language. If you're bilingual in any language and that's relevant to your community, use that and show how you're friendly as well. So there's different opportunities to create a safe space. Before you even engage someone, that safe space, that inclusive environment, it helps somebody cognitively first and helps you initiate the rapport with someone who starts to feel a little relaxed enough to be receptive to what you're going to ask them and how you approach them. So these are really good comments, so thank you for that. I also want to make mention, because I always make mention about this, is the language that we use. We've updated the language over many years now, and so we want to use stigma-free language. Recovery-oriented language is strength-based and person-centered. It's really about empowering individuals and being mindful of what words or what terms are relevant for them, that is important to them, and using that within the context of the conversation. And so I used to speak to, there are individuals who used to access our services in one of my past jobs. And I remember when some folks were in their own recovery process, they will call themselves an addict in recovery. And so an addict, from our perspective, in our language, has negative connotations, because over time, society is good like that, where negative connotations is attached to certain terms. So we don't use it because it could be morally depletive. We don't use it. But if an individual, if my client is using that reference in an empowering way for themselves, I'm going to use what works. I'm going to use their language. I want to respect their autonomy and use the supportive language, the way they understand and that perspective. And most times for me as a provider, what I would use is recovery-oriented terms. And that's what I try to do. And it's still a practice that, that has to be done intentionally. As long as I've been doing this, I still have to make sure I still slip up once in a while, because I am influenced by a lot around my world. But the idea is to be more informed about what works for that individual. And so the culture humility piece has all this. So let me ask you a question. So this is a question for all of you. So the professional developing the person-centered plan, this is a situation. You're the professional developing the person-centered plan, and you focus exclusively on the person served in regards to intervention and advocacy. True or false? This is person-centered. What's
True.
your response? What do you think?
True.
Okay. Is everybody saying true? Remember everything that's been discussed so far? True. Okay. Interesting. So a lot of programs and services, thank you everyone. A lot of programs and services do exactly that. Everything is focused on their diagnosis, on their specific, whether it's psychological, whether it is substance related, whether it is medical or physical issues, and is used specifically around that. But we're talking about person-centered care. I'm sorry to say, but so the professional developing the person-centered plan doesn't focus exclusively on the person in regards to just the intervention and advocacy. What you want to do is take into account their input. That treatment plan, that person-centered plan is only person-centered if it incorporates the very things we've been discussing all the time, which is really about what is it, what are their ideas, what works for them, what are they not willing to do, what is not okay for them, their preferences actually. And so, and their support network, their resources. And so any of the other, whatever other relevant stakeholders may be part of the process. But we won't want to just use only what is the intervention, the advocacy, because their input as what intervention to use is important. And so the approach ensures that the plan actually reflects like the person's needs, the goals, and speaks to their autonomy and their own, self-determination, if you will. And so it's really important to consider that. And this is really what we're used to, but we want to consider that. Yeah, so we can't just do it exclusively on that. We want to make sure that we can do that if we've already asked them, is this what you would like to do? We have these options here. This is a particular approach we can use, or we can use this other approach, and these are the benefits here. We always like to provide information so they can make informed choices. So part of that, and that's part of a person-centered approach, part of that is getting their input. So that plan has to be developed with their input. And so that's my point here. So thanks, everyone. So one of the best ways that we are familiar with that we can engage someone in a conversation is to use preferred language and meaning within their context. And so it was mentioned in the chat box about using language assistance services, or translation services rather. How many of us actually add, let me just ask you, how many of you folks actually use language assistance services? Okay. Next question. How many of us ask every single patient or client we work with what their preferred language is? Gotcha. So the reason I say that is because someone can speak English with or without an accent. Doesn't matter where it comes from. And because they speak well, we might make an assumption that they seem to comprehend well. Speaking the language is very different than comprehending. We're actually mandated federally to ask to provide services in the preferred language. In order to do that, we have to ask. So something as simple as that, instead of making assumptions. So listen, even if they speak English, fantastic. They probably speak English. Most times my clients speak English better than me without my accent. I heard I have an accent, I don't know. But I had to get into the habit, and this is what the practitioners were doing as well. We had to get into the habit of actually asking someone, formally asking and not make assumptions, despite the fact that they can have a great conversation with us anyway, and document that. And document that so anyone else can see it. Whoever is, whether it's a supervisor, whether it's the auditors, most times it's the auditors, but it's a federal mandate and we don't necessarily do that. And the reason for that, why we really need to, is because words can be used very interchangeably, but they mean very different things for different people. And that's just us who speak English. So just imagine someone who may have English as a second language. We want to make sure that we're being transparent and are conveying information with clarity. So this is a helpful part. And so what is it, when we think about the ORs, so what are the benefits of using open-ended questions? Samantha.
By asking an open-ended question, you're going to probably get an answer that's many words instead of just a yes or no. So you're going to get more information.
Right. So you're going to get more information. So don't most of us have to follow, don't we all kind of engage in our clinical protocols? There's certain different data gathering opportunities that we have to do, the initial evaluations and all that, and certain, diagnoses, and certain documentation has to be in there. The organizational obligations and all that kind of stuff. And then at the same time, at the same time, we also know that no matter what the questions that are being asked, when we ask open-ended questions, we get that elaboration that gives us insight for some things that we may not be asking about. It may come out. That's going to help you in your job. Your treatment plan can be the best treatment plan there is, but there's a dimension of reality to a person that comes out when we use open-ended question. It's also a great way to invite somebody into a conversation. So in other words, use an open-ended question, but use it to listen. So closed-ended questions have their place. Probably don't need a lot of elaboration just to get your, your phone number. Probably though, but you do have an opportunity to, they have their place. But when it comes to engaging someone, it's other opportunities as well. When you're asking someone an open-ended question, you're inviting them, you want to hear their voice, you want to hear what they have to say. That person can feel like, oh, you want to know. Let me tell you about that. That is different than a lot of resources that get engaged in the community. That's where you folks kind of make the difference. And the affirmations tend to be a really nice prompt to help you. A lot of our folks don't recognize their own strengths, and sometimes we can see it. And just this is a great way to help someone continue to participate in a conversation. And it doesn't have to happen so repeatedly, but certainly strategically, there's different times when you can send provide an affirmation to someone, and so they can recognize that you can hear them, that you're present with them, that you see them. And so reflections also have their opportunities too. What are reflections for you folks? You ever use reflective communication skills?
Yes, I usually tell people, I hear what you're saying is, and I repeat it back to them what they told me. And then I usually let them know, is this what you're trying to tell me? And then they may say, yes, but I mean it this way. So I let them know that I hear you.
Mm-hmm.
This is what you're saying. Is this correct? And if I'm not hearing it correctly, what do you want me to know? Because a lot of times people can tell you what they want, but that doesn't come out, if you know what I mean.
Right. That's right. Thank you, Malvina. It's just a nice way to people. Yeah, it's a great way. And it's a nice way also to keep the conversation going. And guess who's supposed to be talking?
They are talking to me.
There you go. Thank you, Malvina. And so when we do reflective listening and we just repeating back or using a double-sided reflection or complex reflection, that's a whole other training. But the idea is when we reflect back, we're showing we're present with them. It's a nice way for someone to continue to elaborate, to continue to share information with us. And that's what we can't, again, meeting somebody where they're at, the OIS is a really great way to do it. Matter of fact, they're very basic. Even before motivational interviewing trainings, it was kind of like counseling 101. What are the best ways to engage someone in a conversation? We're using the open-ended affirmations, reflective listening, and summary communication skills. And then motivational interviewing had a really nice way of being able to use those skills very strategically. Many of us got in the habit of using them as a natural way of communicating, of engaging folks. I suggest and encourage everyone to do it with intention. And reflective listening is a great way to let someone know that you're listening. It's a good way for them to reframe what they're saying too. Many times they'll change and they'll hear it different from somebody else's voice, and you get more clarity. And you can and they're better able to explain that to you because you're listening. And so that's one of the most critical aspects of motivational interviewing, is being able to use reflective listening. It's also a good way to develop discrepancy. Sometimes somebody might say something that's maybe a little contradictory. I use a lot of that, or we use a lot of that in the screening, brief intervention, referral treatment training that we do. And we have motivational interviewing mint trainers in our organization as well. It's just such a helpful and non-stressful way for us to be able to use these skills in a way where the person is doing most of the talking and letting us know what's important to them, and we can raise their awareness about a particular behavior. And so then the summarizing is just kind of recapping. Want to recap? You can't be writing a book in front of them, so might as well recap so you can better remember it yourself too. And also let them know that, yeah, you captured everything and add whatever needs to be added. So these different skill sets align with what culture humility speaks to. And so when you elicit all this information, there's different things you're trying to do. You're inviting the person to participate. You know, when somebody needs your help, you want to ask about the language preferences, you want to use recovery-oriented language. So you want to get to know the person. It's a really great way to understand, you know, what's their background, what are their interests and goals. When you invite someone, when you first invite someone, you may have their file in your hand. You may know what they're there for. Ask them anyway. You know, so, you know, my name's Diane Padilla, my pronouns are she, her, and ella. How can I address you? Great. So could you please come with me? I have a space that we can speak in private. Would you be okay if I close the door? So tell me why you're here. Even though I have the file in my hand, have them express and share with me what it is that they're interested in. And so their goals and their needs, a lot more will come out, but their goals and their needs is my first priority. What are they there for? Even before I jump, especially if I like to jump to problem solving, I need to know what their goals are, because their focus is where I have to be at. And so it's the idea is, can they feel supported? Sometimes do we know that there's some trepidation that's coming that comes with their visit to us? Are they elated about some reasons? Just start to learn a little bit about them. And so the four C's of person-centered care. Care is integrate the residents' perspectives, needs, and desires. The second C is culture. Consider their residents' cultural views, their capacity, their resources. Also, the another one, communication, preferred language and transparency on our part, using stigma-free recovery-oriented terms, and being able to always try to partner with the individual, because it's really about helping them in their process, but not necessarily about being the one who is the authority figure and the higher authority within the dynamics of that interaction and that supports that we're supposed to be giving them. And so with that, what I would like to do is I'm going to bring up a slide and tell you what. Where's John? John went okay. Hey, John. So, John, can you do me a favor? Can you read the first part of the slide and then I'm going to read the second one, okay? I'm going to bring it up.
Gotta pull it up, my eyes are bad. I really need to not be around my family who drinks all the time. It makes it so tempting for me to drink too. Then I do not get my schoolwork done and I show up at work half energized. I'm not sure what to do since I live with them.
And to this, I respond, well, it sounds like you're looking to stay away from drinking. We have recovery support groups here that I will give you the schedule for, and then we can also submit a housing application for you. How about we meet in a week or so we can see how things are going then?
Sounds pretty cool.
Yeah. So the question is that person centered or provider driven? What do y'all think? Thanks, John, for reading.
No problem.
See, very good. Oh, wow, that's on top. Okay. All right, so here's what I'm going to ask you all to do. You're right. It's provider driven. You know, I can say with any wonderful tone, any kind of inflection, but I'm making the suggestions. I'm leading this conversation. You know, now I didn't even use any of the orders or anything like that, but I just came out and I got into problem solving. So here's what I'm going to ask. I want you to take out a minute or two, and I want you to reframe how your person-centered response to what John read as the person. Reframe it, and what might that sound like? And I would like you to share it with larger groups. So go ahead, take a minute for that and read the first part. I really need to not be around my family, drink all the time. Makes it so tempting for me to drink too. Then I don't get my schoolwork done and I show up at work half energized. I'm not sure what to do since I live with them. How do you respond to that in a person-centered way as a provider? And who would like to share first? Ask them if there's anything specific they would like to do to try to remedy the situation. Okay. That sounds really difficult. Nice, nice. Okay. What else might you say? You can verbalize it too. You don't have to just put it in the chat. I'm sorry to hear that. What's your goal? Yeah. It sounds like you're struggling with maintaining your sobriety and starting to get your schoolwork and work performance. Okay, reflective listening. This is reflection. Very good. Are you in a position where you might consider moving out? Okay, maybe because that's, I'm not sure whose idea is that. So we don't want to lead the conversation. We want to listen. That sounds like it could be a challenging situation. Can we talk more about why being around drinking is a trigger for you? Okay, I hear you saying, what do you think would help you in the situation? Awesome. Okay, thank you, Samantha. It sounds like you want to stay away from drinking. Have you thought about some ways to do that? Yeah. So this is the idea. Thank you so much. And Dana, it sounds like your home life is impacting your work, school, and sobriety. What do you want to discuss? Do you want to discuss different options? Very good. John.
So I said, you find it difficult to stay sober while living with your family. Drinking interferes with doing your schoolwork. How can we help?
That's great. Yeah, the whole idea here is person-centered means you go to them, ask them what they want. Exactly. Thank you. And a lot of you put it in many different ways, but you ask them. So even though we discussed all this, okay, and I know you're going to get credit from this webinar, but although we discussed all this, we're more conditioned to problem solve. That's a beautiful heart. That's absolutely fantastic, but it has its place. It has its place. Person-centered care, helping problem solve once they start to identify what they want to do. You can come at it afterwards, but the idea is we don't want to lead the conversation. So what do you want to do? Remember, we're trying to work from their perspective. We're using culture of humility to work from their perspectives. What are their resources? What are their strengths? How do they see things? So what do they want to do? You already know different potential solutions and strategies. Hold on to that. Find out what they want first. And so do that. And so in our world, we have been conditioned for a long time to listen. Okay, we listen and says, so listen, I can do a housing application for you. Do you mind if we check in on you, within a week or so? That's what we're conditioned to do. But we need to be more person-centered care. There's a lot of outcomes and surveys that show that people are not accessing services because their needs are not necessarily being met. I know you're working hard. You could take it just a little step further, just to make sure that it's tailored, that it's person appropriate. So culture of humility allows us to kind of not jump in at first, kind of put ourselves on the side and then ask that person. Patrice.
I think that I wanted to comment that even a lot of times I hear people talk about clients' potential, and I think even the use of that word can really take away from that person-centered focus, and it guides us to focus on something that is more provider-driven, agency-driven.
Yeah. So I thank you, and I think that's such a good point. It's I think this whole conversation is an opportunity for us to do that self-reflection. Look at what we do. How do we, and this is not something you have to tell a supervisor, you have to tell colleagues, you don't have to tell anybody. This is just for you. Because you love doing what you do. It's for you to be effective. This is not about putting anybody on the spot. This is about understanding, okay, so when I look at certain things, what do I have a tendency to do? Whatever you learn to do, you can relearn in a different way. You could do that. And you're in position to do that. And so kind of consider how you address certain situations, how you address people in general, and see. Is it more about the courses you need to know and data that you need to gather so you can document? Does it stay there? I know you have to do that, and you kind of tell our clients that, listen, I have to collect this information. I'm sorry I have to write so much. But then when we're interacting and trying to learn about them, are we actually being present in the moment? Are we asking them their field? Whenever we have an inclination to kind of jump in and think, oh, I know what I can do with this person, stop. Just learn to stop, learn to just breathe and just count 5 seconds. Just count 5 seconds. That silence is not a bad idea. It's not just for the person. It's also a nice chance for us to kind of regroup and get grounded in the moment. and just kind of remind ourselves that let's elicit the information instead of guide the individual in a particular direction. It can be so helpful. Just give it a try. Send me an email and tell me how well or how poorly it works for you. I mean, as a matter of fact, that's your informal homework. You will have my email. Please send it to me. If this doesn't work for you, then I will change what I present here. But if it does work for you, after you've tried it for at least 2 weeks, if you make a conscious intention. See, the thing is, when you're intentional, your energy is very focused, you're more likely to do that. But when you're doing it because you have this always fast-paced job and so many things have to be accomplished so many different days that we're not necessarily as mindful as we can be. So try it for a couple of weeks. And please feel free to let me know how that works. So thank you for your wonderful comments. Let me go back here. So importance of person-centered approaches, it makes the individuals feel more comfortable and confident in sharing their world with you and in the services that you're going to provide them. And so it also helps to meet emotional, social, and practical needs, support those who may not be able to directly communicate their wants and needs. Many people do have for different reasons. There's sometimes trauma, sometimes mental health. Maybe there's other issues connected to something else that has nothing to do with you that kind of deters them from being totally transparent with you. And it may take time for that rapport that you have with them, for them to be able to push through, to be able to share with you. But because different people are in different places at different times. But it really does help to support self-empowerment. And though they're more likely to commit to their own recovery and wellness process, particularly when they feel supported, they're feeling heard, their own resources realistically is being considered, and they can help actively participate and engage in their own wellness. And so this is coming from the New York State Office of Addiction Services and Supports. It talks about person-centered treatment plans and how they should be developed using an individual's own language to identify treatment goals and reflect the individual's values, culture, and beliefs. This is what we say. I remember when I was in the field earlier days, we said this, and I was always wondering, but why is it we say this and I speak to this person in Spanish and I still have to write it in English? It didn't make sense to me. These were my early days. I asked a lot of questions, especially when the structures are contradictory. And so it got to a point where I was finally allowed to actually write something in Spanish if the individual's preferred language was Spanish. It was just so interesting how I still had to do it in English and only translate the conversations to Spanish. Person-centered treatment planning includes working with individuals who may have treatment goals other than abstinence. So we already know that recovery is broadly defined these days. Hopefully we're able to work with that. If in the capacity of your work you can't work with that, then provide the support resources that they need that will support their goals. Goal setting should reflect shared decision making and informed choice. And so one of the things that I do know most programs do is if there's a diagnosis, if there's a mental health diagnosis, if there's a substance use disorder diagnosis and the severity level, all of that dictates certain specific appropriate treatment recommendations. And then you put the services according to all that is geared to and designed to help that individual. But if you're doing that without the person's feedback, without providing them options, without explaining choices, and then getting their feedback on their understanding of what the treatment plan can be, then it's not person-centered. It's person-centered from a logistical perspective, not necessarily because the person is involved. So the multidisciplinary team maintains a professional role in forming the treatment plan, assuming ultimate responsibility for the plan, and that incorporates all those different components we've been discussing for all the time we've been together. So it should all be evidence-based, strength-based, and non-punitive. So who should lead the session? I think this is an easy one, isn't it? I would be really, really surprised if anyone put any other option other than B. So thank you, everyone. It should be the client, the patient. We are strategically using our communication skills in a way with intention to help elicit the information we need to understand how to support. We are doing that, but it's really, but because we're working off of what they tell us, it's the client that's really leading the conversation and their process. So I just wanted to share with you that I had found this. I thought it was so interesting There is a culture humility scale that was developed by some practitioners. Thanks, everyone. And it was developed back in 2013, and it's to be able to assess a person's perceptions on culture humility and to recognize how it can be associated with a strong working alliance. And so this is what it looks like. It's only 10 questions. And so again, this is where I mentioned a minute ago about this is for your information, no one else. That self-check piece is so important. And so being able to understand that we are doing this with everyone. You know, all of this speaks to individual, you know, conversation, individual supports, tailored, responsive services. And so, and it's got a scoring and interpretation that comes with that. And so when you access the resource that's cited in the bottom, you will get the interpretation. No screener is of any use if it doesn't have a score and an interpretation. If it doesn't tell you where you're at, then there's no reason to ask the questions in the first place. And some screeners, you know, some people do use screeners without a scoring system. It doesn't have a value for the actual tool. And so this is just a self-check thing. Or you can use the 4 components that I spoke to in the slides when it came to culture humility as a process. And that's enough to help to start to just increase your own awareness about where you're at different times. There's so many things that you folks have to deal with. The opioid overdose rates are through the roof. You have people who are, and something that we don't always recognize, just how much people are impacted by alcohol use, how much the social determinants of health are impacting people's life, all the other traumatic stressors that human beings are just saying are experiencing on a regular basis in today's world. And then they come into services for one particular issue. And these other dynamics impact. The more we understand that, the better we can give them the help they need. And so I know each job is crazy busy and all the responsibilities, but you folks are the ones that help make the difference. So I appreciate that you all were here to engage in this webinar. And if you want to, just don't forget, use the culture humility process and let me know how it went. We do have, at the end of March, we have a course called Culture Humility / Cultural Competence, a Journey to Improve Outcomes. Dr. Dolores Blackwell and I will be co-facilitating that. It's 15 hours. It's 3 4-hour sessions virtually. You already subscribed to our email serve. And so you will learn about that. So in case you need more culture humility hours, this one is much more comprehensive. You'll get all that as well. So thank you all for your participation.